Taylor, how you doing?
I'm doing well, Dr. Beal. How are you?
Fantastic.
Good. Welcome, welcome. Thanks for coming on.
You bet. No problem.
Yeah, we'll give everybody like 5 or so minutes and then we'll do some introductions. I'll introduce you all and then we'll get going.
Perfect. That sounds great. Thanks.
Yeah. Hey, Dr. Jones, how's it going?
Hi, I'm good. How are you?
Doing pretty good. Thanks for joining us.
Glad to be here. What's up, Dougie?
We're waiting on two more and then we'll go ahead and get started.
Yeah.
We'll give it just a couple more minutes. Otherwise, we can get started with who is here and go from there.
Hi, guys.
Hey there.
Hi, Dr. Fandos. Thanks for joining us.
My pleasure.
All right.
We're not live yet, I'm assuming, correct?
We are.
Or, okay.
We are waiting for Dr. Riker, and I'm just making sure he's got all the right permissions here. So let's go ahead and get started. And I'll make sure and grab Dr. Riker as he comes in. So, all right, I'm going to go ahead and get started. So, good evening, everyone, and welcome to today's Less Society webinar. My name is Taylor Headley, and I'll be your host for this exciting session. At Less Society, we're deeply committed to advancing innovation in spine surgery and providing surgeons with the tools and education to deliver exceptional patient outcomes. Today's webinar focuses on a critical and thought-provoking topic: controversies, pitfalls, and pearls in less exposure interventional spine surgery technologies. As this field continues to evolve, it's essential to address the challenges, share best practices, and explore the innovative solutions shaping the future of interventional spine surgery. So we're thrilled to have an incredible lineup of keynote speakers who will guide us through today's discussion. In this order, Dr. Beal is an expert in interventional radiology for many years. He's based in Oklahoma. He serves as the Chief of Radiology Services at Clinical Radiology of Oklahoma. Dr. Jones is an expert in interventional pain and an interventional pain physician at Pain Medicine of the South. Dr. Riker, also an expert in interventional pain and the chairman of Midwest Anesthesia and Pain Management, and Dr. Fandos, another interventional pain expert who is the managing partner at New York Spine and Pain Physicians. Each speaker will have about 10 minutes to present, and I'll be keeping time to ensure we stay on schedule. If needed, I'll gently remind our speakers when time is up so we can keep things flowing smoothly. Before we dive into our audience, just a quick housekeeping note. We absolutely encourage everyone to actively participate by submitting your questions. However, please be sure to use the Q&A section for your questions, which you can find at the bottom of your screen in the Zoom toolbar. This ensures that your questions don't get lost if chatter erupts in the meeting chat, and we'll address as many of your questions as time allows during the Q&A portion. That's all I have. I know we're not interested in hearing me talk, so I'm going to pass it over to Dr. Beal if you're ready, and we'll get started.
Thank you very much, Taylor. It's great to be with everyone. And I would like to start out by saying I'm going to have a discussion um, about SI joint anatomy. And we will talk primarily about the variant portions of the anatomy. And this is something that's near and dear to my heart. This is also something that goes by the moniker. You may not have seen the variant anatomy of the SI joint, but it has seen you. And so with that, we're going to focus on how the posterior approach is affected, and I'm going to relate that to the lateral and posterolateral approach. So initially, the posterior approach is something that has been in discussion a lot lately. It's been in the literature. It has a CPT code 27278. And we are discussing now the persistence of that CPT code in 3 of the Medicare administrative contracting units. So it's widely regarded to be very safe. First bone dowels were put in 2012. You probably heard that, but these are not cortical allografts. These were fibular strut allografts, and so that's very different. And then we have some data showing equivalence, and this is one of the most important slides that we have. We have 2 levels of data. Sets that compare triangular titanium bars. And these are randomized control trials, the InSight and IMEA, one's US, one's European, and that's respectively. We have an SI fusion registry done with laterally based cortical screws, and that's in green there. And all the results I'm showing you are in VAS and ODI. Then we have the secure trial that was done with cortical allografts. So you see that these are all fairly comparable. One of the things we do notice, though, is that the fluoro time is markedly less for the lateral-based screws in the cortical allograft than they were the triangular titanium bars. The operative parameters are also a lot better. I didn't put those on there, but those are things like op time, blood loss, post-operative patient recovery, and then we notice that the length of hospital days is a grand total of 0 for the laterally based, minimally invasive screws, as well as the cortical allografts. This is something that I've been noticing recently. I've seen a few posts of the posterior placed allografts on LinkedIn, and this is just a basic review of anatomy relative to what I think we've all seen a lot lately. And so the cartilaginous portion is peripheral, mainly anterior in light blue. Extra-articular recess or ligamentous portion is in the purple part in back. But what we really see in the lateral view, we see a combination of the sacral body, and that's what we see the most and most easily seen, in combination with the sacral ala. And the ala is not that well seen. So the ala goes all the way out to the cartilaginous point, but the part that we really see is the sacral body. And this is a vestigial disc, S1, S2, S2, S3, and that's what everybody aims for. And that's what we see the most easily in the lateral view, so therefore that's the landmarks. Here's something I just picked up off of social media, and it shows the placement of 2 cortical allografts. I've highlighted these because they don't have markers in them. And these are placed, and one is placed, the inferior one is at S2, top of S2, and is placed posterior to what was perceived, I think, as the anterior cortical line. But that's not the anterior cortical line. That's if you draw the anterior cortical line, that's the sacral body, and keep in mind the sacral joint is next to the sacral ala. And so these are not placed anywhere close to the cartilaginous part. And that's maybe okay, may not be okay, but at least we need to know that that's where we're placing these grafts, these implants. And the implants wind up at a place like this in the extra-articular recess. And so the one on the left is placed in the extra-articular recess, just as one on the right. There's one intra-articular, but if these are designed to go in there, that might be okay. But I don't think these have enough distraction arthrodesis capability to provide enough tension, or certainly to provide enough contact with the cortical and the subcortical bone to produce long-standing fusion. So one of the things that I'll kind of defy everybody to do, or encourage everybody to do, maybe a better way to put it, is to look at SI joints. And these SI joints are 4 that I lifted randomly. as Taylor mentioned, I am an interventional radiologist. I'm board certified still in diagnostic radiology. So I do some core lab work for assessing devices. These are four I randomly just pull off of an assessment for the Aperius device for spinal stenosis, something completely unrelated. But these are not SI joint analysis cases. These are just four, maybe out of 10 that I randomly pulled, and you can see that the SI joints is side to side is one's serpiginous, one's more straight. You can see an accessory SI joint in your upper right. You can see the extra-articular recess has different sizes in the low left, and this is a osseous protuberance or an exostosis down there. And so, as it turns out, this has actually been studied. This is, article by Trinidad initially for the accessory or supernumerary SI joint, and then article by Varique studying the variant SI anatomy. And this is the accessory SI joint is the number two there. That's the one we recently saw. The bipartite is not that important. Iliosacral complex, semicircular defect, crescentic ilium, and all of these, including dysmorphic sacrum and the synostosis, is important. And these are important because, and I'm going to highlight these are the ones that are most important, because they can either block an implant placed from the back, this accessory SI joint on the left, this synostosis in the middle, and this is a dysmorphic sacrum on the right. So you can either block it or it can obstruct your view. Down low is an iliosacral complex, and this is crescentic ilium. The point is, when you have your eye there, the part that you see as the joint is an amalgam of the cortical lines. The greatest density, the greatest amalgam of the cortical lines is where you see the joint. And as you see on the image, the CT image, the joint looks like it's right there. It looks like it's anteroposteriorly oriented, but this is kind of at the bottom toward S2. And as we know, the bottom joint flares out just a little bit. So it's fooling you. You're going to be hitting medial to that joint to get into it. Anybody that's done SI joint injections from the posterior portion can feel that pain right there. And as I mentioned, this is the article on Trinidad. And if I mention these articles and you're unfamiliar with them, don't feel bad. These came out this last year in the radiology literature. So this says is that the accessory or supernumerary SI joint, the one seen in the extra-articular recess, not only common, it's present in over a quarter of the patients. And whenever it is present, it's present more than 50% of the time to be bilateral. So this is something that's present. It's ubiquitously common. We'll take a look at some more of these accessory SI joints that I again pulled from a core lab assessment of a spinal stenosis spacer. And so these are something that's really common. You see them all the time, and they may block or impede the access to the joint. And so this is another article by Varique, and this is the anatomy that I have shown you previously. So not only are these variant anatomy, not only are they common, so Varique said that over 80% of the patients in this had some form of the 8 types of variation that I just showed you. And then he, I think, wisely came to the conclusion that this is really not variant anatomy. This is just normal variations of anatomy, he said was a better way to put it. So early in my career, we used to fuse SI joints with partially threaded 7mm screws. You put them in, you'd wait a while, they'd back out, then you had the fully threaded screws, you put them in, wait a little bit longer, then you back out, and then we put them in with cement and a bunch of other stuff. And it wasn't really until the 3D printed screws or the nice machine screws that we got placed laterally that we really had confidence in doing this to have the bone ingrowth. But nevertheless, I think the future includes some type of cross-sectional navigation. And there's problems with the existing navigation systems applying that to SI joint fusion. I won't go into that, but there are problems with the systems and they have to be worked out. So either CT guidance, which is hard because the gantry is so small, people don't use CT outside of some IRs. And then intraoperative navigation would be nice to really get around things like the accessory SI joint and even a synostosis, to be able to see that and be able to know that that's what's happening. And to be able to know that's happening, to be able to look at this beforehand, a pre-op CT is not nice to have. It is mandatory. And you need to have in a coronal axial and sagittal views, and this is basic T12 to S1. You can put it in a navigation system. These are thin slices, or you can have Stark protocol here and to have it all three planes, plus to have an oblique plane along the longitudinal axis of the joint in that oblique plane. And so this is an advanced view, and this is something that is beyond the scope of this discussion, but it's certainly nice to have. And so bottom line is that the posterior approach is effective, but it has impediments to doing this. You have to be aware of the SI joint and consider the SI joint, and the variation in anatomy is absolutely not common. It's ubiquitous. And so you have to understand that this is present, that it may impede your mechanical access and visualization of the joint. My go-to is a lateral, and sometimes my second one is a posterolateral, almost always. And I do that because it's easier. You don't have to worry about getting it stuck into an area where it's inaccessible. You have to plan this preoperatively. You absolutely have to understand what type of anatomy you're getting into, because not only is this anatomy common, it is the rule rather than the exception. So the knowledge of this anatomy, along with your pre-op CT and planning, is absolutely necessary to optimize your ability to fuse the SI joint. And when you do so very well, as you've seen from the VAST and ODI improvement outcomes, this procedure is one of the best things not only that we do, but one of the best procedures and surgeries that are done. And with that, thank you guys very much for your attention.
Thank you so much, Dr. Beal. Dr. Jones, if you're ready to go next, feel free to start anytime. I do see some questions in the Q&A box. Just a reminder that we'll get those here at the end.
Let's see. Share screen. All right, how do I do this, Taylor? Where's the share screen?
Share screen is at the very bottom of your screen. It's a little green arrow. It says share at the bottom.
Gotcha.
Mm-hmm.
All right, will the Zoom difficulty? All right, sorry, computer's acting up. Okay, can everybody see? All right, I'm Marcus. Thanks everybody for joining tonight. I'm going to talk about a little kind of a more of a real world discussion of my experience with InSpan so far. So I've been doing it for about a year and a half, and results have been really phenomenal. And I encourage everybody who's interested in checking it out to do some due diligence and see if it's right for you. But it's really changed my practice. So I'd like to discuss my experience with it so far, little patient selection, little technique pearls, nothing too in depth in terms of the technique, but just little tidbits that I picked up over the couple of years I've been doing it. And then I wanted to go over a couple of cases, some home runs, and then a difficult one. All right, so patient selection is obviously incredibly important. You're going to do your standard history and physical. You can try all conservative measures. I mean, most of us are going to be pain docs, so we'll have that capability in our wheelhouse, injections, so on and so forth. When you get down to the brass tacks, though, I mean, obviously, patient symptoms and in line with the imaging. Always get an MRI and flex X films. CT, if the patient has contraindication to MRI, can be an alternative, but it's going to be, you can get tricked, especially with soft tissue stenotic pathology on CT. And then the main indications are going to be, you're going to see facet tropism. You can use this for facetogenic pain. stenosis, obviously, and then you're going to be looking for any instability or spondy over 3 millimeters. You can also use this for a wide variety of indications, like a adjacent segment. As you can see an image on the right, that's one that I did a few months ago. Patient's doing great. Okay. So technique, really the only things that I wanted to share with you here are going to be when you're first starting out, you can try and align the end plates as much as possible, get a nice clear picture of the interspinous space, but especially with the more difficult spines, just take a lateral image so then you can really see the interspinous trajectory more clearly. You can see I used just a sponge stick on that image to find the L4-5 interspinous space right there. Otherwise, if you don't check that beforehand, I've had a couple of cases at the very beginning, my first two, dissected down and I was off by an inch or so. So that's a helpful little trick. When you're dissecting out the multifidus, I would encourage you not to just rely solely on the spade, but try and dissect as much as you can with just a bovie. That'll really minimize bleeding postoperatively. And then lastly, on the technique, I'd say, so you can see the compressor on the top with the two introducers. You want to line that down as close to the patient as low as possible. And that'll give you a lot more power in terms of cranking it as completely closed as needed. You need the two ports to align so the set screws can lock down. If you're up higher, you're really going to struggle with it. And then lastly, set expectations. We like to harp on how this is less invasive than traditional spine surgery, and it is. But and going over that, you really need to stress to the patient that this is surgery and that they're going to have significant postoperative pain. So that's and typically in my experience, I've seen, when I see the patient postoperatively at 10 days or so, then they're a little unsure. They're like, wow, this was a lot more painful than I was expecting. And then by the next month I see them, they're flying. All right, let's get into a couple cases. So I'm going to talk about 3 different indications and successful, like very successful cases that I have. And then lastly, we'll go over a difficult one. So this is this was a 65 obese female who had failed. You'll see a running theme in these cases. So they failed injections, obviously, and then SES, as you can see there. So she had central stenosis of very severe 3.4 millimeters and a dynamic spondy of 8 millimeters. And she had been wheelchair bound for the past year. She hadn't been able to walk or do any of her ADLs. And this was a classic one where she saw me post-op and she wasn't completely sure that she had done the right thing going after this surgery. It was a little less suspicious, but then next month I saw her. She walked in without the wheelchair, and just I'm very, very happy with how she had done. And you can see the sagittal and the axial cuts up there. You can see definite severe stenosis, and then you can see the spondy at L4-5 in the bottom too as well. All right, this next one is a 62-year-old male who failed conservative measures and spinal cord stimulation. Surprise, surprise. Not a lot of spondy, but severe L4-5 central stenosis, 3.8 millimeters, really bad neurogenic claudication, ridiculous signs. And he also had this really intense, sharp groin pain. He said it felt like it was in his testicles. Another great case, L4-5 in Spain. You can see the post-op images up there. Completely gone, the groin pain and the radicular symptoms, and a significant reduction in back pain as well. Okay, this is an interesting one. 53-year-old female with some stenosis, very mild, meters.
Hey, Mark, I'm sorry, can I interrupt you for a second? I was just checking the chat. Can you, some people are only seeing slide 4. Can you reset the share slides? Can you unshare and then reshare? That may help.
Of course.
And while he's doing that, if you guys do have some questions, just don't feel free to put it over the Q&A or the chat. And
how's that? Are we seeing all the slides now?
So let's see here.
I don't see it.
I
I'm
still see slide 4. I've got
Yeah,
slide 4 now.
yeah, me too. I'm frozen on slide 4.
Brand new computer, of course.
Thank you, Dr. Beal, for pointing that out.
Sure thing. If you put it in presentation mode, it looks like we've got your share now.
Okay. Man. Okay, we're seeing it.
I don't see it yet, but
So I have it, but it's not in presentation mode.
Okay, maybe if I keep it in this one, it'll be better. All right, we're on slide 5 now.
Yes.
Okay. All right, I'll circle back to the first cases just so you can see it. So this was the wheelchair-bound female who got her up in ambulatory again after L4-5 inspan. See the sagittal cuts, severe stenosis, 3.4 millimeters, bad facet tropism, a lot of fluid in those facets as well. And to reiterate, this is just a patient that, again, managing expectations postoperatively, and then the natural course that I've seen over in terms of how patients recover. Here's the 62-year-old man with not a lot of spondy, but severe stenosis at the groin pain, radicular pain is completely cleared up. All right, this is interesting one, really terrible L4-5 facets. See that bright white line as the fluid buildup. See not terrible stenosis, but developing mild. And after inspan L4-5, very happy, cleared up the facetogenic pain terrifically. And another thing to point out about these first 3 cases is they're all really single level disease, including this patient. The superior and inferior facets were much less affected. And I think that's a big part of why she did well. Not to say that I only treat patients with single level disease, but these are good cases to focus on. All right, this is onto the difficult ones. This is 37-year-old gal, had a L5S1 failed fusion, had obviously failed injections, another failed stimulator. And so on MRI and on exam, she had some developing stenosis, about 6 millimeters, moderately adjacent segment disease above her prior fusion. And then the only other real significant finding was some moderate foraminal stenosis at the right L4. Physical exam, everything lined up perfectly with this. I mean, she had very clear-cut straight leg raise and L4 dermatome. Felt pretty confident about doing it. So afterwards, got a call a couple of days later. She was in excruciating pain in the right leg. Got an urgent CT. Everything looked fine. Brought her in, did some injections, tried to quiet it down. Figured it was just some post-operative injury to previously stenotic regions. And over the course of time, it really didn't get that much better. So I was like, wow, is this SI joint? Did I completely miss this? So got an EMG, no sensory or motor deficits. Did a couple SI joint injections, and you can see in the bottom 2 images. Ended up doing a posterolateral sacrix on her and cleared it up. So I think that speaks to, even though you got to be really, really rigorous with your diagnostic regimen and how you work them up. And even in that case, I mean, I was pretty confident I was doing the right thing. We did get some benefit with the back pain with the inspan, but ultimately she was most symptomatic at that SI joint, which is glad we got her cleared up. All right.
Thank you, Dr. Jones. That's really interesting to see inspan in real life like that. Dr. Fandos, if you're ready, and I'll just reiterate one more time, there are some questions in the chat. We'll save those to go over as a group in the Q&A section here at the end. Dr. Fandos, feel free to take it away when you're ready.
Yes. So I didn't prepare any slides because I wanted just to have it as an open discussion. I thought the format was going to be more of a type of a podcast. So I wanted to chat a little bit about coding and reimbursement for InSpan and Sacrix. And when I started doing InSpan about 3 years ago, I was using the CPT code, the same code that we had used in the past for Vertiflex and interspinous devices. And I had a really difficult time getting approvals. But then I kind of modified the technique, the way I did it. And if you analyze the way the InSpan procedure is being done, you're actually decompressing the spinal canal by removing the interspinal ligaments and some of the lamina as well. So I went through different stages on coding. So I started initially with a 22867, which basically was the interspinous device code, which I had a hard time getting approved. And then I tried using a different approach that will fall within the guidelines of the procedure. And some of the physicians that I work with suggested to use 63047, which is a laminotomy or laminectomy code rather. The issue with that code, it also carries the foraminotomy as a description in the code, and we don't really perform a foraminotomy when the InSpan procedure is actually done. So I think based on how the procedure has been done, the best code to utilize it would be 63030, which is a decompression of the spinal canal. We definitely do that. By removing the interspinal ligament and removing some of the lamina. And in addition to that, by utilizing the InSpan device, you're actually fusing at that level because you're not only putting claws into the spinous processes, but you're also adding bone graft. So technically you're performing a fusion. And you can add a second code, which is 22612, that completes the billing for that. And I've seen a lot better reimbursement. And actually, I was able to get the procedure approved much easier. And provided that the surgical technique satisfies the code, there's no issue with reimbursement. Some of our colleagues in the neurosurgical arena have not been happy with us utilizing this code because this is a similar code that they use for fusions using pedicle screws. But the truth is that based on what we do surgically, this code definitely can be utilized. And I have not seen any issues with payers, even commercial carriers. There are a couple of other codes out there that can be used when you're utilizing the nanofuse, which is a 20930, which is, most of the time is not reimbursable. Most of the insurance companies deny it. So I don't bother anymore utilizing that code. So the two main codes I focus on are the 22612 and the 63030, which are spinal fusion and decompression. And like I said, I haven't really seen any major issues with getting authorization and being reimbursed. And as far as the sacroiliac fusion, that's pretty straightforward. The only code that we use is the 27280, which is basically the transfixation of the SI joint. That's the main code.
27279.
Yeah, exactly. The other one is the open code. The 27279. So that is the code that calls for transfixation. We used to utilize that code in the past when we were placing devices, distraction devices, but that has changed over the last couple of years. And now, in order to utilize that code, you have to actually transfix the joint, like we do with the Sacrix procedure. And I have not any issues with reimbursement on that, provided that you show documentation on how the procedure has been done. I don't know if you guys had any issues utilizing those codes for the SI joint.
So can I jump in here just for a second? I just kind of first in, first out. So codes I use for InSpan are 22612, 22840, 20930. And this is arthrodesis, instrumentation, and allograft, respectively. And so these are pretty tried and true. I don't mind using the posterior instrumentation code, but it's the same instrumentation code. If you read the code, it's exactly the same as 4 screws and 2 rods, and it's agnostic as to what you use. So that should pass muster pretty much anywhere else. A little primer, again, a review on the SI Fusion. 27278 is the distraction arthrodesis in the joint, something that doesn't, I'm going to use a couple of different terms. The final terminology is not set. The old terminology is transfix. New terminology is pierce. Doesn't do any of those. It's a distraction arthrodesis. And regardless of material, it can be cortical allograft, it can be titanium alloy. And then the 27279 is a transfixation code, usually from a lateral or posterolateral approach, but the posterior approach with transfixation is a 27279. And then, of course, the 27280 is an open approach. Right. So that's something that, for example, some of us, would you do an open approach? I use an 80 if you're using something like a Nadia screw. You with a kind of a mini open or an open procedure, but that's something to use only if you use an open approach.
Correct. Yeah. So the most common code is the 79.
Yep. Exactly.
So I don't know if you want to take any questions at this point.
We'll let Dr. Riker do his bit before we step into the Q&A, if that's all right.
Yes, absolutely.
Perfect. All right. Well, thank you, Dr. Fandos, and thank you for adding in Dr. Beal. Dr. Riker, when you're ready. I think you're on mute there. There we go.
All right, you can hear me now. Sorry, my computer stopped working, so I had slides and I can't even do that presentation now.
No problem. We're glad you're
Anyway,
here.
so I've done a lot of SI fusion using the Sacrix screws. As you know, historically, it used to be an open procedure many years ago, started in the 1920s. A lot of complications from those procedures. And then it went to minimally invasive lateral approach. And now people are doing posterior approach. And they were doing the lateral oblique approach, which was a Medtronic approach using the Rialto screw. I basically improvised on the procedure, and it's a new procedure, posterior oblique approach. And I got a paper out, which is now in the Medica LCD guidelines, and I'm hoping it will be gold standard in the future. I don't mean to be arrogant, but there's a lot of neurosurgeons across the country that are using the posterior oblique approach. The approach is so simplified. Like Dr. Beal was saying, there's variability in the SI joint. You have to review your anatomy before you do this. However, the way the posterior oblique approach, the way I designed it, it's almost foolproof, or you can't make any mistakes. You're going right through the sacrum from the posterior aspect of the sacrum into the joint and into the sacral LR. And you get fantastic fusion from this procedure and stabilization. And that's what you need to do, is get stabilization. The ultimate goal is to get fusion from the stage. The paper that I wrote, we had almost 100% fusion rate on the people that had follow-ups from this procedure. I've not done the posterior approach, but I've seen a lot of failed posterior approach that we have revised. The lateral approach is good. However, it's a big procedure. You're going through dissection through the gluteal muscles. You got to be aware of the gluteal neurovascular bundle. You got to dissect around the cranial nerves. There's a lot of things that can go wrong, but the incidence is low. That's why I'm such a proponent of the posterior oblique approach, because it reduces the risk to almost zero. Blood loss is almost minimal to none. It's an outpatient procedure, and patients have recovered within a week or less than that. So having said that, let me move on to the inspan. As you know, these are distraction plates. You can do with rigid fixation or with dynamic soft fusion. The inspan is done with rigid fixation. And there are studies out there that shows that they're almost as stable as pedicle screws. You got great results for neurogenic claudication, ridiculous symptoms. Anybody with disc bulges or disc herniation, the pressures are reduced. And in the segment where you put the inspan, recurrence of disc bulges or disc herniation is reduced quite a bit because you're decreasing the intradiscal pressure quite a bit. So a lot of advantages to doing the inspan. Indication is really for spinal stenosis with claudication, but we've done it for spondylolisthesis up to grade 2, mild, moderate, even up to severe spinal stenosis. I've done 2 cases where people had disc extrusion with foot drop, and we saw resolution of the foot drop within a week or 2 once inspan was done, and people were back at work. One of the workers was a truck driver, the other one was a carpenter. I haven't done the facet fuse yet. I'm waiting. I'm doing my analysis on whether this is a good procedure. The preliminary results of what Dr. Chin is doing with other physicians is looking very, very promising. And the nanofuse is a home run. I use nanofuse with all my cases. So I'll take questions after this. I'm sorry that my computer broke down and I could not do my slide presentation.
No problem. No problem. Thanks for joining, and it was fabulous nonetheless. And we have several questions that we can dive into. I'll go ahead and read the questions that were submitted. Some have a particular expert that they're asked to, and others do not. So it'll be told in the question if there is this particular expert. The first question is, with respect to the posterior approach, the SI joint is a synovial joint and I believe is continuously secreting synovial fluid. Do you believe that you can truly accomplish solid good fusion with allograft or titanium intra-articular implants? And with some of these implants being small, do you feel if the patient had a fall that any fusion would be strong enough to withstand that fall? Dr. Beal, I see that you answered in text. If you maybe want to start, and then anybody else who wants to answer can chime in as well.
Sure, yeah. Well, it's a joint somewhat like a synovial joint. Look, this is not a diarthrodial joint. This is an amphiarthrodial joint. This is more like a symphysis than a real joint. Is there any fluid in the joint? Yes. How much? Very, very small. And so all you have to do is worry about essentially the AO principles on fusion. You have to decorticate. You get down to bleeding bone. You have to make sure the implant is a snug fit in the right location. So I talked about extra-articular recess versus the cartilaginous anterior portion of the joint. It doesn't matter. You can put screws and big devices back into the extra-articular recess, and it fuses just fine. Fuchs and Rule, Wise and Dahl, John Stark had a good screw that did just that. But you just have to use good principle, and so you have to worry about what I worry about is placing some of these cortical allografts too far posteriorly. Is we're not getting a snug enough fit. We're not prepping the bed, the decortication down to bleeding bone, and the use of grafts, including autografts. So yeah, just use the basic principles, and that should be just fine. And I've numerous cases. I've got numerous stacks of CTs showing good fusion on clinical study follow-ups.
Let me add to that. I think Dr. Beal did a good job of explaining what the SI joint is like. you can get fusion through the posterior approach if it is pretty snug. But if it's loose, that the grafts are going to migrate into the sacrum or the ilium. That is a problem. Yeah, like he said, you have to use good principles and really implant those implants snugly. If they're not snug, it's not going to work. You're not going to get a fusion at all. So that's one of the I mean, there's a lot of variability during the posterior approach. You take that variability away when you do the posterior oblique approach. You're maintaining the natural angle of the SI joint. I mean, when you do the posterior approach, it is a distraction procedure trying to achieve a fusion. And that's a big if. With the posterior oblique approach, you are definitely maintaining the angle, compressing the joint, and fusing the joint. And that's why I'm such a firm believer of the posterior oblique approach. And I hope everybody experiences this approach and appreciates how well it works.
The last thing I'll add onto that is I used to do some of the posterior approach, and patients all did very well. But coming up on a year or so post-op, most patients tended to have resolution of symptoms, and so now
I lost with
the posterior lateral approach.
I would like people to use the posterior oblique because that's in the Medicare guidelines right now. Posterior lateral is a whole different approach than the posterior oblique approach, and the results of the posterior oblique approach is much better than what Medtronic originated with the Rialto screw.
Posterior oblique, sorry, not lateral.
So.
Great. Is there anything else that needs to be added? If not, I'll move on to our next question, which was directed at Dr. Jones. And Dr. Jones, I see that you answered in text here, but just so everyone can hear, the question is, Dr. Jones, what are your thoughts on using nerve block local anesthetic on the segment facets along with the and above and below segment facets prior to starting procedure to reduce post-op pain?
Yeah, like I said in the chat, I mean, I think that can be a strategy to help with some of the immediate post-op pain. Obviously, there are lots of different types of local you can use. I do use quite a bit of local for incision, some Marcaine with epi and a little Lido mixed in. And most patients are pretty comfortable coming out of surgery. I think where that could be more useful with nerve blocks is if you're have some question about which level to approach, and then you can use that to parse down which is the most symptomatic level. But that's more where I would use that rather than as a strategy to reduce post-op pain.
Great, thank you. Next question is for Dr. Beal. Dr. Beal, would you advocate for combining lumbar endoscopic frenotomy and InSpan to treat lumbar spinal stenosis to both increase the height and breadth of the foramen?
Yeah, that's a good idea. Anything endoscopically that you can use to visualize the decompression, I mean, that's part of the code. So if you can use that to visualize and decompress it, absolutely, that's a good thing. Having said that, comparing, if you look at the data that's been done on the decompression with the posterior interspinous spacer, proportionally, you get more increased diameter, more luminal diameter in the neural foramen than you do the central canal. And so this is done. We saw this back all the way back to the early studies. Jim Zuckerman showed this with X-stop. And so if you were to pick one that needs a little bit of extra help, it would be the central canal. So yes, the endoscopic decompression of the foramen would be good. A yellow ligament decompression of the central canal would be even better to give it a little bit more decompression, to resect a little bit more of the ligament flavum. It has a yellow appearance on endoscope. That's why some people call it a yellow ligament decompression. That would be even better.
Great. Thank you very much. Another question. Some people have used 22840 spinal instrumentation along with 22612. What are our thoughts there?
Well, that was my original comment that I said I used 22612, 22840, and then 20930 for the allograft. So that's kind of my standard.
Great. And then 27280 is only used in a hospital setting, correct?
That is correct. Do
Yeah.
not, yes, do not use, that's an inpatient code, and it's not to be used elsewhere.
Great. Okay, and somebody asked for to repeat the codes for InSpan. I have 22612, 22840, and 22930. Moving on to the next question. Dr. Beal, given your comments on the variability of sacral anatomy and understanding the great variability of the lateral recess, what are your thoughts on the catamaran implant that is placed posterior, inferior, ventral to the recess in the most dense part of the following true AO orthopedic principles?
Yeah, that doesn't allow for joint prep is the only thing, but catamaran and any of these that span the bottom part of the joint at the bottom of S2. So the bottom of S2 is much, much less variable than S1. L1 is not variable. S1 is all over the board. Almost all of the variation happens at the lumbosacral junction. So if you're going to do something like that, come from the back, it really it would behoove you to go at S2 at the bottom. So I like the technique. It appears to stabilize the joint. What we haven't seen is a lot of data from them, and so I like the other parts that transfix the back part of the joint. I've seen X-shaped devices that go in at the bottom, and so my opinion on this is that they are clearly effective. And I've seen biomechanical data on this, and it is as effective as triangular titanium bars and the Rialto screw, as was brought up previously. What I don't know is how well it works clinically, because there's kind of a paucity of data. So I'll say my professional opinion, as we don't really know yet.
Thank you. I'm getting another question for Dr. Jones. Any tips on getting InSpan approvals through insurers? What are your thoughts on combining a flavectomy with the InSpan procedure via non-endoscopic approach?
I was anticipating a lot of pushback from insurers when I started doing this, but I haven't had that much pushback, honestly. I think the important things to when you're submitting for it is you obviously have to have all the correct imaging and document that there is some spondy. Typically, you're going to be able to find that over 3 millimeters, and then just a summary of all the treatments that they've failed. They've had the typical stuff. Like I had one patient who they demanded that he stop smoking for 6 weeks. He wasn't a smoker, so. I mean, you'll see stuff like that. In terms of the flavectomy, I think to echo what Dr. Beal was saying, you don't rely solely on the decompression from InSpan. I would encourage you to be pretty aggressive with your decompression with the rongeur, taking out a lot until you really have a nice soft opening that you can feel with your finger through the incision. And that's I think an important part, because you can really depot quite a bit. Started.
I actually have some nice templates that I utilize for patients that are candidates for InSpan. And they work pretty well for me. I could share those if anyone is interested.
They also have them on the KIC website. They have a good templates and documents that you can pull from, which I do.
Yes, that is correct. There's a lot of resources on the website.
I just want to make a comment on a catamaran. Historically, catamaran is a boat that was invented in India in the 5th century. It's basically two logs joined together by two logs in between to make it float. The best catamaran is doing the posterior oblique approach. You have the ilium and the sacrum, and you're putting two large screws. You're creating your own catamaran. It doesn't get any better.
That's a
I
good one.
love it. Oh, wow, that's great. Dr. Riker, here's a question for you in the chat. What's your concern with your facet views, and what's on your mind? What's your mindset about that procedure?
Well, one of the biggest pain generators in the spine are the facet joints itself, right? InSpan does such a great job, and if someone has facet-mediated pain, you are taking the load off, putting an InSpan, and your facetogenic pain goes away. It's an amazing device, these interspinous devices, if you choose the right device and do the procedure correctly. We are talking about less surgery in the future. I hope people realize that this is a indirect decompression or closed decompression. You're not taking the ligamentum flavum out. That would be an interspinal procedure with all the risks of old-fashioned surgeries of putting the pedicle screws, like having dural tears, hematoma formation, nerve damage, all those things. We're not doing that. So my concern is if you're putting screws to those facet joints, I can understand it for stabilization, for spondylolisthesis, things like that. But when it comes for facetogenic pain, I'm a little wary of using the facet fuse because I don't want to irritate those joints anymore. And that's my concern.
Thank you. In the topic of facet fuse, we have another question here. How strong is facet fuse in comparison to pedicle screws? I don't know how much experience we have with facet fuse, but if anybody wants to answer that one, please go ahead.
I've seen recent data, but old data biomechanically, the pullout strength is the same, and you'd say, how in the world is that possible? Next time you look at a CT, look at the pedicle, look at the vertebral body, and look at the cancellous or medullary bone inside there, and then look at as an example, 65, 70-year-old, even female of Northern European descent. Look how sclerotic the bone adjacent to the facet joints are. So that's some of the most robust bone in the body. It allows for a little bit more flex and extension. The last paper I saw was 2.9 degrees and flex X a little bit more allowance than pedicle screws, but functionally about the same. So these are pretty good. It's just and it's kind of a reverse of doing a pedicle screw. Instead of starting the upper outer portion of the pedicle and kind of going in and down a little bit, these things are placed upper inner portion of the lamina. It's kind of aiming at the superior medial portion of the pedicle you can see on fluoro and putting it into fairly horizontal into the vertebral body. So it's for those of you that are used to putting in pedicle screws or doing vertebral augmentation and bilateral transpedicular approach, it's pretty easy.
Thank you. We're running out of time here. We have a few more questions. We'll see how many we can get in. There's another question in the Q&A box. Is InSpan superior to Minuteman in achieving posterior lumbar fusion? That'll be an interesting question. I think maybe all of you have done both.
There's no comparison studies on it. So, I mean, I think in our non-randomized, non-placebo control study of our own uninformed opinions in this regard, we can say what we want, but there's no data on that.
All I can say is I don't know how we can achieve the anterior placement that you get from the InSpan with the Minuteman. I highly doubt it if you can, and I cannot believe you can get solid fixation like you can with the InSpan-like device that you can with the Minuteman. That's my opinion on it. Like Dr. Beal said, there's no comparative studies out there.
Well, if you look at the technique, you're not doing a facetectomy, which you do with InSpan. The spinous process, you're not getting the decortication that you get with InSpan either. So you're not exposing that bone to promote fusion. And then lastly, if you look at the design of Minuteman versus InSpan, the locking mechanism is a lot more robust on InSpan. There's just a plate that screws in on the other side with Minuteman. That being said, no studies back that up.
So I'd like to just point out real quick that Kingsley just put up in the webinar chat the comparison. It put the title of the comparison between facet fuse and then pedicle screws. It was published Journal of Spine IJSS in 2024. So thank you, Kingsley. That's very helpful.
Yes, I think we have time for one more question. In the Q&A box, we have Dr. Jones mentioned a big change in his practice with devices such as InSpan. Can you comment on patient selection and pain management with SCS, heavily used by pain physicians, versus InSpan to treat their pain?
For a long time, that was the best thing we had in our wheelhouse was stimulators, and we used them, overused them quite a bit, which is echoed where the ramifications are seen in the decreasing reimbursement, et cetera, for STEM. But you weren't really able to treat structural issues, which you are now with the Saprix and InSpan, et cetera. So it's much more gratifying to be able to fix a patient's problem like that versus with the stimulator, and plus the breadth of what you're able to treat is much more. It's just completely opened up with the access to these less invasive surgeries.
Yeah, I think, let me just add something else. I remember back in the day when kyphoplasty became, a great procedure for spinal fractures, and that changed my practice back in the day. And I feel InSpan has given me the same ability to treat structural problems now, as opposed to just treating the patients with injections and pushing the ball down the road. I think InSpan has given me the ability to treat patients with severe spinal stenosis that they have no answers, because they go to the surgeons, and most of orthopedic spine and neurosurgeons do not want to operate on these patients, and they have really poor quality of life. They're very sedentary. They can't do anything, and InSpan has brought life to these patients.
Well, the way it's changed my practice is that I only send 1% of my patients now to spine surgeons for surgical procedures, and that is a true answer. I'm correcting a lot of my procedures using the InSpan for spondylolisthesis, spinal stenosis, disc herniations, disc bulges. Practice of spinal cord stimulation hasn't changed much, because indications are more indications now, but from diabetic peripheral neuropathy. So there's other indications to do spinal cord stimulations. And I'm not seeing, over the past 5 years that I've been doing InSpan, the rate of failed back syndrome in my practice. Patients are happier, and I'm getting more referrals from primary care physicians, and also getting referrals from neurospine surgeons. When they don't want to do pedicle screws, they'll send them to me for InSpans. So that's how it's helped me.
Great. Thank you all so much. I know we're over time. We have one last question from Dr. Chin. His question is, what is the difference between CPT code 63047 and 63030?
63047, I think it's mostly for aminotomy as well, more than the decompression of the spinal canal. I believe that. I can look it up.
Yes, he said in the chat, the descriptor for CPT 63030 states that it is for the removal of a herniated disc, while CPT 63047 is for the decompression of spinal stenosis.
Yep.
Okay.
I'd like to thank everybody. I've got to jump off.
Yes.
But listen, I really appreciate everybody being on. Great questions, good discussion. You guys did an awesome job. So
Dr. Beal, thank you for always bringing your expertise as a radiologist with all the anatomic variations, everything. It makes things clearer to a lot of people, including myself.
Appreciate it very much.
Thank you.
Yes.
Cheers, you guys. Good to see you.
Cheers. We've had lots of people in
Thank
the
you,
chat
everybody.
and in the question section say thank you so much for your expertise, everyone. So thank you all so much for joining us. Thank you to the attendees for coming. We hope you come again. Good night, everybody.
Thank you.